This slide's presentation will provide an overview of the pathophysiology for Guillain-Barré syndrome, as well as the physical therapy management of this patient population. This slide shows some statistics that are available for people with Guillain-Barré syndrome. You should know that it affects individuals of all ages, but it is most common in both males and females between the ages of 30 to 60 years old. It affects males 3 times more commonly than it does affect females, and you can see this in the chart on the right-hand side of the slide. You can see this pictorially in the graph that's on the right-hand side of the slide, where the numbers in the legend represent 10-year age categories for these individuals, and on the far left-hand side you can see the number of males in each of these age categories, and slightly to the right of that, the number of females. It affects 1 to 2 people per 100,000 per year will be diagnosed with Guillain-Barré syndrome, and this is approximately 3,000 to 6,000 people every year. The pathophysiology is described on this slide, where Guillain-Barré or GBS typically occurs 2 to 3 weeks after some sort of infection. The kind of infection can vary, and a number of the responsible organisms are listed here. Campylobacter jejuni, which causes an intestinal infection, is the most common infection preceding a diagnosis of Guillain-Barré. Okay, the others are listed there, but you should know that Campylobacter jejuni is the most common. It's also minimally associated with immunization against the common flu. You should know that this disease is autoimmune mediated, and it involves the degradation of myelin around peripheral nerves specifically. And if you remember, the peripheral nerves are myelinated via Schwann cells. What actually happens is shown on the right-hand side of the slide in the picture, where the healthy nerve has the myelin sheet wrapped around, or the Schwann cell wrapped around the axon of the nerve, where a nerve that is affected by Guillain-Barré syndrome actually has the myelin degraded and the nerve fiber is exposed. This results in a much reduced neuronal conductivity. I talk about Guillain-Barré syndrome, but Guillain-Barré syndrome can be a number of different types. Okay, the first, which is known as acute demyelinating polyradicular neuropathy, AIDP for short, is what most people think of as Guillain-Barré syndrome. It is the most common type, representing 85 to 90% of all the diagnosed cases. Okay, another kind of Guillain-Barré that you might hear about in your clinical future is known as acute motor axonal neuropathy, or AMAN. It only involves motor symptoms, and there is typically no cranial nerve involvement, and it has a very good prognosis. Another kind is the acute motor and sensory axonal neuropathy, or the AMSAN. It itself involves mainly sensory, and the Miller-Fisher syndrome is recognized through the involvement of cranial nerves, especially cranial nerve 3, as well as having patient ataxia and areflexia. Okay, the final variant is it's its own kind of demyelinating problem. It's known as chronic inflammatory polyradiculopathy, or CIDP. CIDP is considered very different than the AIDP in that it results in relapsing or progressive numbness and weakness. It's similar in presentation to Guillain-Barré, but it can recur, and researchers typically look at this patient population differently. On the right-hand side of the slide, you can see the picture that I've chosen, and they're just different subtypes for Guillain-Barré. But one of the first things that I'd like to call your attention to is the sideways Ys that are there around the axon for that neuron. These Ys actually represent antibodies that the body is producing. Like I mentioned previously, it is an autoimmune disease. It has been shown that the infection results in the body producing antibodies against the infecting organism. However, that infecting organism has parts that mimic proteins that are on the outside of the myelin sheath. It's autoimmune since the body makes antibodies that then go ahead and recognize and start to destroy the outer coating of the myelin. Okay, typical presentation. So for this, I'm just going to talk about GBS or the AIDP. It's very standard presentation. It's typically symmetrical weakness, and that weakness, patient complains about distal to proximal progression of weakness. So what happens, that person may have had some sort of infection a couple of weeks before, and then they start noticing that they're having muscle weakness. If it's bilateral and symmetrical and it's distal to proximal progression, then you should think possible Guillain-Barré syndrome. After the weakness starts, there's a rapid progression and an actual plateau, and that plateau is known as a nadir. It's usually anywhere from 2 to 4 weeks after the onset of weakness, and it is the point where the symptoms from the patient are at their worst. During this time, that person could have, then after this time, there's a recovery period where there's improved muscle strength 2 to 4 weeks after nadir. Okay, signs and symptoms to be aware of in this patient population is that weakness is going to be greater than sensory loss for the standard AIDP or GBS syndrome. Okay, consciousness is usually spared and cognition is spared as well. The patient might complain about paresthesias, which are tingling and numbness. Usually it's in a stocking and glove pattern, or also pain. Pain could also be due to something known as a hyperesthesia, meaning that this patient population is very sensitive to touch. Okay, most standard symptom is going to be weakness, motor weakness, whether it's paresis or paralysis. Paresis is a word that just means basic reduced strength in a muscle, and paralysis means that they have absolutely no movement or they're shooting zeros in that muscle group. You should be aware that it might include muscles for respiration. So the patients, I think 85% of them require ventilatory support. They also have decreased or absent deep tendon reflexes. Cranial nerves, the motor nerves are most often affected. These are the motor nerves for eye and facial movements, chewing, as well as swallowing. The diagnosis of GBS, for the diagnosis, is progressive weakness of one or more limbs. Usually begins in the lower extremities, and as I said, the progressive weakness goes distal to proximal, absent or decreased DTRs in the limbs that are having weakness. Supportive of the GBS diagnosis is autonomic involvement. A large percentage, something like 70% of this patient population has autonomic system involvement. They may also have some sort of cranial nerve involvement. Approximately 50% have cranial nerve involvement. The pattern of weakness is typically symmetrical, and the pattern also has been shown to peak between 2 to 4 weeks, which is considered the nadir. And that person might also have elevated protein levels in their cerebrospinal fluid, but that takes about 2 weeks to appear. And they may also demonstrate nerve conduction velocity decreases after several weeks. Other potential complications to be aware of in this patient population: they are very much predisposed to DVT or deep vein thrombosis. And again, just a quick review of DVT is shown in the picture on the right-hand side of the slide, where the normal limb, lower extremity, is shown on the left, and the leg with the DVT is shown on the right. You should expect or may expect throbbing or pain in that area. The skin may be warm to the touch. It might be red or darkened in some way. The leg's probably going to be swollen, and you might actually see swollen veins there. Again, if you suspect DVT in any patient in your future, this is a medical emergency, and you are not to do anything with that patient. Okay, other problems could be pneumonia, deconditioning. Fatigue is huge in this patient population, especially during recovery, and we'll talk about that a little bit later. I said dysautonomia, 70%. This includes blood pressure issues, bowel and bladder issues, and respiratory failure is relatively common in this patient population. That's going to be about 30% of the patient. I'm talking about that with respiratory failure. This is going to occur in the first 12 weeks of illness. It is going to require ventilatory care. Okay, predictors of respiratory failure include onset of weakness to admission to the hospital of less than 7 days, inability to cough or stand, the patient can't lift their head or elbows, or there's increased liver enzymes. You should know that if you see a person in the clinic and you're in an outpatient setting and they come in with weakness progressing distally to proximally, you should send them to the ER. due to the possibility that they could have GBS and may require ventilator care. Okay, as far as medical management, the kind of more of the phasing out these days is something known as plasmapheresis, which is just plasma exchange. You can see an example of a person on plasmapheresis here on the right-hand side of the slide. Its job is to remove the antibodies that are attacking the Schwann cells. So it should be performed within the first week and may require a couple of sessions if the person has mild symptoms, but with severe symptoms, it might require more than 4 sessions. With the plasmapheresis, like I said previously, this is kind of an old school medical management. Currently, the most common medical management that you're going to see is called intravenous immunoglobulin therapy, also abbreviated IVIG. Okay, the IVIG therapy is an intravenous administration that neutralizes the antibodies. It results in decreasing inflammation. It has mostly replaced the plasma exchange because it's easier and more convenient, and it just requires 5 treatments over the course of 5 days. Okay, with a person that has been diagnosed with GBS, there's going to be 3 different phases. Okay, the first is the acute phase. In the acute phase, there's a rapid progression of symptoms, and as I've said several times previously, the symptoms peak at 2 to 4 weeks, and this is known as the nadir. There's next going to be a plateau phase. During the plateau phase, the symptoms stabilize. This plateau phase may only last a few days, but it can last for many months, depending on the patient. And the recovery of this patient population is going to be variable from person to person. Finally, there's the recovery phase. This is a gradual, spontaneous improvement in symptoms. And as I've mentioned previously, that time frame is going to be individualized to the person. If you look at the image on the right-hand side of the slide, you can see that orange line is indicative of the infection. So typically a couple of weeks before the person presents with weakness, they're going to have some sort of infection. Okay, whatever infection it is causes the antibodies that I talked about, and here they're labeled as anti-glycoside antibodies. Don't really need to know that, but these antibodies are specific for a protein on the outside of the myelin sheath. Okay, once those antibodies start being produced, then you can see shown in blue is the GBS timeline of progression. In the beginning, at time 0, once those antibodies reach their peak, then you start to see the weakness, and that weakness is pretty quick. Over the course of 3 weeks, then you reach your nadir, and then slowly there's a recovery function over time. Okay, this time course only shows 12 weeks total, but realize the recovery can take a year. Okay, this slide talks about the prognosis for patients diagnosed with GBS. There is a mortality rate of approximately 5% due to respiratory complications. That's why it's really important if you suspect GBS in a patient, progressive weakness, decreasing DTRs, going distal to proximal, and relatively symmetrical, this is a time to send that person to the ER. They might need ventilatory support sooner rather than later. Okay, overall, you can expect a complete functional recovery in 85% of the patients. Having said that, there are about 15% of the patients who do not recover full function. Most are going to be ambulatory. About 80% are going to be ambulatory 6 months from when the symptoms start. But 50 to 60% of the total are left with neurological deficits. Even though they're functional, they may have difficulty with power or diminished reflexes, even after 1 year. GBS usually doesn't recur, but about 5% of the time it does recur after 8 weeks. And this is going to be considered the CIDP that I talked about earlier, a completely different animal. On the right-hand side of the slide, on the very bottom, you can see there's a disability scale for GBS. If that person is healthy, they have a 0. With minor symptoms, they're still capable of running, they're a 1. They get a 2 if they're able to walk without support of a cane, but they're not capable of running. And 3, they're able to walk with a cane. 4, they're confined to a bed or a wheelchair. 5, they require assisted ventilation, so mechanical ventilation. And 6, they've died. Okay, this is the overall disability scale for GBS that you should be aware of. On the top right of the slide, this is from a recent article looking at patients 1 year post GBS. You can see that approximately 25%, as shown in the pinkish color, receive a score of 0 or healthy. Many, almost 50%, are able to receive a 1. They're capable of running and they only have mild symptoms. Shown in purple are the number of individuals who are able to walk, but they're not able to run. Moving on down, you can see that at 1 year post-diagnosis, there's nobody that's going to require ventilatory support. Working this patient population, the PT examination should consist of, first and foremost, very important vital signs. Make sure you take the person's SATs to make sure that they're breathing properly. If they have cranial nerve involvement, you might also need to augment communication with this person. They might not be able to speak. Another thing you're going to be checking for is the presence of pain. Okay, pain, if you remember, can be in the presence of those hyperesthesias that I talked about, or the pins and needles patient might complain of. You definitely want to check for skin integrity. This is going to be huge because if this person's lacking mobility, they might not be able to move in bed by themselves at all. You want to be absolutely positive that there aren't any pressure sores starting anywhere. Active passive range of motion, going to be an important part of the examination, as well as early treatment. Gross motor testing, if the person has any muscle strength at all, you want to identify it. This is a patient population where you want to look for DTRs. Sensory check should include both proprioception and light touch sensation, upper extremities and lower extremities. If they have any movement available to them, you can also attempt to test their coordination, whether it be upper extremity or lower extremity. You should test cranial nerves, especially cranial nerve 3, because that's the nerve that's most often involved in this patient population. If the person's able to sit up or stand, you can test their balance. If they have any functional mobility, you definitely want to be testing this, especially their ability to roll in bed to help prevent pressure sores. As time goes on and the person is able to start doing activities, you want to monitor for fatigue. This slide shows some general goals for patients with Guillain-Barré syndrome, especially early on. Our main job is going to be to minimize their pain and desensitize any dysesthesias they may have. And a dysesthesia is just an unpleasant sensation, and examples of kinds of sensations that these patients may report include burning, hot or cold sensation, the feeling of anything crawling on them, electric sensations going down their arms or legs, feeling wet or sharp piercing pain, the pins and needles, as well as just generally itching. We also want to prevent contractures and pressure sores and injury to any weakened muscles. So this would include any splinting that would be necessary and supportive adaptive equipment. We want to try and optimize strength and endurance and prescribe adaptive equipment such as wheelchairs or other assistive devices and this will vary. What that person needs will vary throughout their physical therapy treatment time, because remember, their recovery is going to last about a year. During this time, they might also need orthoses, such as an ankle-foot orthoses. As far as PT interventions are concerned, I chose to break it down via week, because sometimes it's hard to know what to do with a person who can't really do anything for themselves. But in week 1, you can expect this person to possibly be intubated with an endotracheal tube. They're going to be ventilatory dependent, and they might have complete cranial nerve paralysis as well as tetraplegia. Our treatment is going to consist of postural drainage. This is required every 3 hours. Passive range of motion to all joints to help maintain range of motion during the time when they can't move. Splinting to maintain functional position. So examples of this would be the multi-POTUS boot that we talked about previously that has the little kickstand on the side to help prevent that lower extremity from rolling into internal and external rotation. It helps maintain that hip in a more neutral position. OT might be more involved in using hand splints to help maintain the hands in a more functional positioning. As well as another area where we're going to be heavily involved is in turning that patient or positioning. So you want to make sure that that person every 2 hours is switched into a different position to avoid the contraction of pressure sores. Okay, during weeks 2 through 5, okay, this is the time of the nadir when their symptoms are going to be at their worst. If that person is still having pulmonary function issues, they might have to receive a tracheostomy, and they're still going to be ventilator dependent. At this point, you want to provide postural drainage twice every 8 hours. Again, passive range of motion, splinting, and positioning. And they may also require something called desensitization therapy. And this is for any pain or hyperesthesias that they might have where they're sensitive to all touch. So what you want to start doing is slowly and gently applying a little bit of touch to help that person become adapted to the feeling of touch. And you can also provide family education, and they can definitely be helping at this point with range of motion and positioning. Week 6 or 7, this is time when the person is going to be started to wean off the ventilator if they were ventilatory dependent. They might not have any active muscle contractions except for eye opening and lip movement, in which case your treatment, again, is going to be your postural drainage, your passive range of motion, because they have no active range of motion yet, your splinting, positioning, and as far as trunk is concerned, it might be a good time to start building tolerance to upright sitting. Okay, this would be using the facilitation techniques that we talked about previously to make sure that there's good trunk alignment. Remember, upright against gravity is going to start to get those extensors firing. And the family should still be involved with the passive range of motion and positioning. Weeks 8 and beyond, about week 8, it's going to be patient dependent. Realize that everybody's recovery is going to be a little bit different, but at approximately week 8, you might be seeing palpable muscle activity in the neck, trunk, and extremities, particularly in proximal musculature of the upper and lower extremities. This person may still require postural drainage, and now's the time to start to get them on the tilt table. But when you do so, please remember to monitor their vitals, because the percentage of this patient population that has dysautonomia. And as the strength returns, you want to start adding active range of motion. Okay, the most important thing about the active range of motion here is that you're going to take frequent breaks and monitor fatigue, but you're only going to work in gravity eliminated positions. Okay, you want to start in gravity eliminated until that person has a full 2 out of 5, so full range of motion, independent range of motion in a gravity eliminated position, plus a little resistance is tolerated. Okay, this is super important because you want to avoid something called overwork weakness. This is very common in this patient population. You can easily overdo it. If you have an overwork weakness, is just nothing more than delayed muscle soreness, and it results in a reduction of maximum force production, and this typically happens 1 to 5 days after you've done the activity. Okay, it's going to result in prolonged weakness in strength and endurance due to the overwork weakness. It's more likely to occur with eccentric contractions, so we definitely don't want to be doing anything eccentric with this patient population. If the patient is presenting with overwork weakness, you may see weakness, spasms, or soreness. To avoid this, you want to work with low repetition at higher frequency. You don't want to work against gravity until that person has a 3 out of 5. And you might want to teach the person energy conservation. And so because of this, there are some precautions for exercise prescription. If the person is actively undergoing axon remyelination and repair, you want to avoid overwork. You want to avoid eccentric contractions and wait until muscles are anti-gravity strength before using against gravity active range of motion. Okay, this slide just shows some additional resources that might be helpful for future patient education, as well as support for patients with Guillain-Barré.